I will introduce our speakers.
Hi, everyone. Hi, Richard. Hi, Jacqueline.
Hello.
Hello. Rob, indeed. Hi, Rob. Nice and early for you?
Yes, very early.
Very honoured to
Hi,
have
Jim.
people from Australia logging in at 11 o'clock at night for the start of a webinar. That's pretty impressive.
Dedication.
Absolutely.
Dedication. Well, excellent topics, always, as always.
Okay, so it's a couple minutes past 2, well, UK time, so we're going to get started. So hello, everyone, and welcome to today's session on the AFINet webinar series. As I mentioned, my name is Jacqueline Carhoon, and I'm going to be chairing today's event. First of all, we are so glad that you could all join us for today's important discussion on adult siblings of individuals with substance use problems. As many of you know, the AFINet webinar series are dedicated to sharing knowledge, research, and lived experiences about families and individuals affected by substance use and addiction. And today's conversation focus kind of sheds light on the role of siblings and how their lives are shaped by these experiences. So I will apologize in advance for my pronunciation, but it's my pleasure to introduce our speakers, Dr. Torleif Halkfjelsvik and Dr. Solveig Christiansen. Dr. Halkjelsvik is a psychologist who received his bachelor's and master's degrees from the Norwegian University of Science and Technology and his PhD from the University of Oslo in 2012. He is currently a senior researcher at the Norwegian Institute of Public Health in Oslo, as well as an adjunct research scientist at Simulamed. His work spans a wide range of research with a particular expertise in substance use and in judgment and decision-making. Our other speaker is Dr. Christiansen, who is a demographer whose research focuses on the connections between family life and health. She brings extensive expertise in the use of Norwegian registered data and has many years of experience analyzing family and household-based patterns at the population level. Her work highlights the powerful ways demographic and social factors shape well-being across the life course. So we're very pleased to have both of these speakers joining us today. And now I will give the floor to them, and after we'll open up for questions and discussions.
Thank you very much. Do you hear me now?
Yep.
Good. We're happy to be here. Thanks for having us. So just a question, do you see only the PowerPoint now or also this Teams window? It's only the PowerPoint, right?
I can see the PowerPoint.
Okay, great. Then it's like it should be. Okay, thank you very much. So these are unfortunately preliminary results now because we had another round with a review we got to know that a couple of days ago, so it's still preliminary, and we have to wait until we release these numbers. So please do not cite things we present today. So this project is a collaboration with an organization called Ivareta, which is an organization for family members affected by substance use. And yeah, it's a collaboration between them and the Norwegian Institute of Public Health. And we are thankful for the contributions of the collaboration group and also a group of affected family members that participate as consultants. It has been very helpful with this collaboration between us researchers and more practitioners. So today we will present some results from an article that Solveig and I have written with Agnes Melvin and Øystein Kjærdahl. And this is the adjusted name of this paper. It's the socioeconomic, health and family situation of adult siblings of patients with substance use diagnosis, a descriptive registry study. So some background. Siblings are often a resource for individuals with substance use problems, both practical, helping with different services and forms and things like that, and also emotional. Siblings of individuals with substance use problems, they may also have a high risk of experiencing challenges themselves in domains such as family, work, and health. And this could be due to a role as a caregiver. It could be due to growing up with a sibling who develops substance use problems, but also the shared genetics and environment. So we're not concerned with causes here, because regardless of these mechanisms, knowledge about how these siblings are doing in important life domains could be helpful to inform policies and family-based support for substance use. There is some previous research. The most studies have been qualitative, so this registered study is a bit novel. In past studies, it has been reported that siblings experience depression due to their situation, and that family members report adverse work-related outcomes, for instance, sickness absence. And students who have relatives with problematic substance use, they are more likely to be delayed in their studies. And siblings of individuals with alcohol use disorder, they show an increased risk of attempting suicide. And siblings of patients with substance use disorder have more children than the general population. It's also a characteristic that has been reported in past research. So our research aims are to explore the life circumstances of siblings of individuals with substance use diagnosis. And we're particularly interested in siblings who do not have substance use health records of their own. This group has a potential dual role as a resource for the patient that can alleviate pressure on social and health services, but they are also likely of higher risk of using some of the same services. And this is a group rarely covered by existing policies and rights and treatment programs. It's rarely included in substance use research as well. So the overall approach to our study is to use the Norwegian registries. So it's a pure registry study, and we have no surveys or other information, only things that are in administrative registries in Norway. So these registers are quite good in Norway, and they cover the entire population. And it is possible to link administrative registers in Norway by this personal identification number. and it's pseudonymized, so we don't have like access to personal direct personal information. And we can link the population registry to health records. And in this project, we have access to the years 2008 to 2018. And we can link data on family situation, employment situation, and healthcare utilization. And we do this for the year 2018. So there's a lot of data, a lot of registries, and we're happy that we were allowed to link these registries for this project. It's from a larger project with a lot of other topics, so we are part of this bigger registry linkage. So our data sources in this study is the Norwegian Population Register, and we have used the National Education Database and the Norwegian Patient Register. We also use the Primary Healthcare Register, and these are different. One is for specialist healthcare and the other is for primary healthcare. And we have a database on social security and benefits, and we have household registry. So linking these gives a lot of opportunities to see how the situation of these siblings are. Okay, more about the methods. So we have different measures from these registers. We have demographics, and these are mainly from the population registry, where we can where it's the legal gender is registered, age or birth year, and the immigration background. We also have the data on the highest completed education from the National Education Database. For the topic family, we have data on children, the number of children and when they are born, and the age of the parents at first birth. We have data on marital and cohabitation status, and we have the geographical distance between patients or the individual with diagnosis and the sibling. Now this is based on driving times between municipal administrative centers, so it's not really accurate. It's not like house to house, it's just municipality to municipality, or that these are registered with within the same household. And we can see if there are children of the patient in the household, that the sibling live with a nephew or a niece. That is the children of the patient, yeah. And we have within the topic employment and benefits, we have data on full-time employment, which we have made from an income data. And we have a part-time job variable, and we can assess sickness absence, which is medically certified sick leave, and it's only for those with income from work. And in Norway, you can also have a sickness absence of shorter period of time for like 3 days without medically certified sick leave, but we don't have data on this. So this is like from a medical professional certified sick leave. We have data on benefits and pensions, like unemployment benefits, work assessment allowance, which is like a temporary disability pension before you actually get disability pension. And we have data on financial social assistance, which is kind of the last resort if you don't have enough money to pay for food and your rent and things like that. We have healthcare utilization data, which is from the primary healthcare system and from the specialist healthcare. And we separate between consultations and hospital admissions. And hospital admissions are inpatient care exceeding 1 day. in somatic institutions. So these are the measures, and then we had to identify these patients whom we are interested in their siblings. And I'm not going to into all these details here, but the patients are mainly those registered in specialist healthcare within this study period with the classic substance use diagnosis called F1. So these are the main substance use diagnoses we use for the ICD-10, but we also used more somatic diagnosis, and they're mostly related to alcohol use. We chose not to define those with a single intoxication episode or two as patients here, because we thought that, okay, this could happen when you're young without necessarily having a more severe challenge relating to substance use. In addition to these classic substance use diagnosis, we included those who had in total 3 or more consultations of intoxication, or who had been to the general practitioner and received a code indicating substance use challenges. So this was to get a more severe patient group than if we had included everyone that had any type of diagnosis. And we excluded the tobacco part of this F1 diagnosis. So this was the patients, but these are not the one we are interested in. We are interested in the siblings of the patients. We found those by using the registered mothers of the population, and those who were aged 20 or more, who had the same registered mother as the patient. They were the group of interest here. The reason for not, well, this is about adult siblings, but the reason for not having siblings under 20 are also because they have no meaningful data on the variables we are interested in, because we have variables such as partnership status and labor market outcomes. So a summary of the methods for this study. It's a pure registry study. Our data sources are the Norwegian Health, Education, Population and Employment registries. Our measures are demographics and education, family-related variables, employment and benefits, and data on health utilization. We identify patients mainly by the ICD-10 F1 diagnosis, mental and behavioral disorders due to psychoactive substance use, and somatic, which is mainly alcohol-related diseases, and also repeated intoxications and or primary healthcare consultations with substance use codes. And the siblings of these patients were those who were 20 or above and had the same mother as the patients. So the samples and subsamples we used here were 3 groups, and the first group we call SUD siblings, which is like it's not the D is not disorder but diagnosis, so substance use diagnosis siblings, and this group included all siblings of patients with health records indicating substance use problems. In this period of time, we found 155,000, but we were most interested in a group we call SUD siblings excluded, which I will refer to just as the sibling group. These are a subsample that exclude those who have their own substance use health records. So we focus on this group. some would find it natural that we focus on this group, but we had challenges and explaining this choice to others. So I just mentioned why. It is because those who have substance use diagnosis, they are also in the patient group, and they would be covered by research, policies, and treatments that target substance use. But this group is potentially a better position to support their siblings, so who have substance use challenges. They're likely better than sibling pairs where both have substance use problems. And we would like to describe a sibling group that is distinct from the group of patients. If siblings have substance use diagnosis of their own, that will typically be a more severe problem than being a sibling to another person with a diagnosis. So there are a range of services and treatments available for patients, but we are interested in the needs of the group of siblings who are not substance use patients. Nevertheless, we do present figures for the inclusive group as well, but it is this excluded group we will focus on here. And for this group, we made a comparison group of siblings from the general population that also had no personal health records relating to substance use. And we matched these groups by age and gender. And in contrast to the identification of the patient group, we have like strict criteria. This excluded group excluded any consultation whatsoever relating to substance use. So it's a more lenient criteria for excluding those in that group. So let's go to the results. I'll just start with counting the number of siblings. So in our data, we found 103,000 patients, and these had 155,000 adult siblings. And this is approximately 4% of the Norwegian adult population. The true prevalence of being a sibling in Norway, it's uncertain due to the need for the linkage through the mother, and sometimes we don't have the registered mother. If we use the criteria any diagnosis or consultation relating to substance use, this figure goes up to 6% siblings of animals. So first, which substance use diagnosis did the patient and siblings have? In the patient group, what we present here is the last recorded diagnosis. So typically, many had a lot of different diagnoses, but this is the last recorded. And for the patients, alcohol was the main diagnosis, and we see also that cannabis is quite high and opiates is high, and a lot have a polydrug and other diagnosis. So if we go to the siblings' own diagnosis, it turned out that only 14% had substance use diagnosis themselves. And as I said, this criteria were more lenient, like it was easier to get the diagnosis for the siblings here, because this is any consultation. So we expected these figures to be higher, but of course there could be undiagnosed cases, but the threshold was quite low to get into this group. So 86% of the sibling group did not have a substance use related code or health record. So to the socio-demography here, and here we have this excluded group which we focus on, and the comparison group. So I will talk about these two groups, and this is just here for the record. So these two are those I will talk about. we see that, of course, these are exactly similar on sex and age because these are matched on these variables. So if we go to immigration status, we see it's not there are not big differences, but there are some. But it doesn't account for more than like a percentage point difference there. So it's not like a main characteristics of the sibling group here. However, if we look at the education level, we see quite substantial differences between these age and gender matched groups. So the SUD sibling group had about 11 percentage points higher only compulsory as highest education, and about if we count both the higher education categories, it's about 11% lower levels of higher education in the SUD sibling group. So that is a central characteristic of this group in our data. Now to the family related data. We first show the age at first birth for those who have children, and we see that there is actually a substantial difference between the comparison group and the SUD sibling group, where teenage births and teenage pregnancies are more common in the SUD sibling group. There is also generally lower age at the first birth, which we can see also in the next category here. And of course, in the opposite end of the scale, we see that there are more persons waiting to get children in the general population group. In terms of the number of children, there is not like a really consistent pattern, but we do see that there are generally somewhat more children in the SUD sibling group than in the comparison group. So there are more that have four or more children, and but there are and also less that has no children. If we go to partnership status, we also see that there are differences. If we look at the divorce separated row, we see that even though there are fewer who are married, or there are more that are never married in the SUD sibling group, there are still a higher number who get divorced or separated in this group. And I only show the percentages here, and I think in research you would often expect that we have some like p-values or confidence intervals, but I think the important here is like the absolute values, because the uncertainty is very low. The 95% confidence intervals here typically would correspond to the 0.2 percentage point plus minus the difference. So like the differences you see are the differences we find. There's not much uncertainty here. And you can also approximate a p-value by looking at non-overlapping confidence intervals, which in practice here would mean that if a difference is more than 0.4 or up to 0.6, then it's statistically significant on that level. So we haven't focused much on that because the uncertainty is quite low. So more about the family situation. We considered it interesting to look at the distance between the person with diagnosis and his or her sibling, because we don't have any data on like how close their relation is or if they have any contact. But in the registry, we can at least see like the potential for having contact. And we do see that there is a quite high percentage who lives in the same municipality as the patient. Most of the sample, most of the siblings, they live within 1 hour driving distance. So either in the same household, which is about 3%, or in the same municipality, or a quite short travel time. So this was a bit interesting because it suggests that these have the potential to be involved in the lives of the patients. Then we had a look at how many had children of the patient in their household, and it was not many. There were some. So one child in 0.2% of the siblings, and 2 or more was very rare. So it's not common to grow up with an uncle or aunt if you have a parent who has substance use diagnosis. Okay, so now to the next topic, which was employment and benefits. And in this analysis, we have limited the sample to what we can call like a working age from 25 to 66 years. And we see that a large majority of the sample is in work. It's almost 70% that has full-time employment, and 12% who is part-time employment. However, these numbers, at least the full-time employment, is quite low in comparison to the general population group. So there's like a 9 percentage point difference in the number who have full-time employment among the SUD siblings. So there are somewhat more who have part-time employment, which could be linked to the fact that they have a lower proportion with full-time employment. If we look at those who have work, those who are in work, and there is sickness absence, we see that there is more sickness absence. The proportion who have reported any sickness absence is somewhat higher in the SUD sibling groups. And if we look at the number of days, the average number of days, the difference is almost 4 days. So it's 4 more days of sickness absence among the SUD sibling group. So even if this group is more selected, because it has like a lower proportion here, so even if it's more selected, we see more sickness absence. So if we go to benefits and pensions, we also see that this group is likely experiences more challenges relating to the labor market. There are more with unemployment benefits, and there is a higher proportion with work assessment allowance, which was this temporary benefit you receive often while you apply for disability pension. And we see on disability pension that there's a substantial difference. It's like almost a 6 percentage point. And that corresponds to about 50% difference between these groups. Also, when we consider the financial social assistance, in absolute numbers, it's not very much, but in relative terms, it's like a 130% increase in the use of financial social assistance during this year, 2018. So we see substantial differences here when it comes to employment and benefits, where it looks as the SUD sibling group has a weaker attachment to the labor market. And this table is the working age sample, and we also wanted to have a look at the part of the sample that was within the typical student age, which was considered 20 to 24 years. And we wanted particularly to look at the higher education. And as we see here, the potential challenges in this group starts quite early, because we see more than a 10% difference in who is enrolled in higher education during the age 20 to 24. And yeah, this corresponds to about 35% difference. So this is quite substantial. When we look at the benefits and pension, which is not very common in this group, but still we see quite high figures in the SUD sibling group here. There are more unemployment benefits, more work assessment allowance, more disability pension, even in this young age, but particularly the financial social assistance is high in this group, with a more than 6% difference between these groups. And in relative terms, this effect corresponds to a 140% difference. So this underscores the socioeconomic position of this group, and that it appears challenging even at a young age in adult life. The next topic is health, and we start with a table on physical health. So if we first look at this general practitioner consultation, primary healthcare consultation here, we see quite high numbers, but this is actually common. A lot of people visit their general practitioner during a year. So it's high, but it's also high in the comparison group, but it's somewhat higher. It's like almost 4% points higher in the SUD sibling group. So more people go to the general practitioner among the siblings. If we look at the number of consultations, it's also slightly higher, with like half a consultation on average, higher in the SUD sibling group. If we count hospital admissions, it's also interesting to see that this there's a difference here, and this difference is about a 20% increase in the risk of being admitted to the hospital, which is quite substantial. Then we had a look at more specific codes and specific diagnosis in the data. So for cardiovascular disease or conditions, we counted the number of people who had any consultation relating to cardiovascular disease and conditions during that year, like 2018. And the difference here was quite small. Overall, it doesn't look like the cardiovascular area is the one with most challenges in this group. Still, we see more hospital admissions in this group, with actually a 25% decrease. For musculoskeletal, we see a larger difference with a 3 percentage point increase in consultation, like the number of people who go to their general practitioner with for these conditions. And one interesting pattern we see here is that if we go to physiotherapy, the pattern reverses. So there's actually, it's like it's somewhat counterintuitive that they appear to have more problems relating to musculoskeletal conditions. Still, they use physiotherapy less, and we believe this could be a sign of underutilization, but perhaps they do not use health services as much as they need. In terms of specialist healthcare, for musculoskeletal disorders, they are also higher. And for hospital admissions, we also see a small increase, corresponding to about 17% increase. So we do see some areas where there are not that large differences, and others that suggest there are differences, and perhaps there should be even more differences if they used health services as much as they should, because it's very difficult to interpret health utilization data, because it's not really directly how their health are, it's how their health are in addition to how they use health services. And within this physiotherapy, we also have a chiropractor or a manual therapist, things like that. So this was mainly physical health. We also looked at mental health. For mental health, we see larger differences between the comparison group and the SUD sibling group. We see here that there's a almost 5 percentage point difference between this group, which is like a relative increase of 40% in the SUD sibling group. And this course, in terms of the number of consultations relating to mental health in the general practitioners, it looks small, but it corresponds to a 42% increase here. So in terms of specialist mental health care, we also see substantial differences here. In absolute terms, the numbers are low, but on relative terms, this is a 50% increase in contact with specialist mental health care of any kind. Then we had a look at more specific diagnosis relating to mental health, and we see that 1.5% have anxiety, which is in absolute terms quite low and close to general population here, but in relative terms, it is a 50% increase in risk. And the same for depression. It's only about 2% who had depression that year, and that's about a 50% increase in risk for this SUD sibling group in comparison to the general population. And eating disorder was quite rare. Still, in relative terms, it's about the same effect size as the above. Perhaps the condition that was mostly differed between these groups was this stress and adjustment disorder, which has like almost a 70% increase in risk. So there's a lot of numbers here, and I understand if people can't follow, but it is, eventually we will release these numbers for you. So, okay, so to summarize, there were substantial socioeconomic differences and differences in health utilization between siblings of patients with substance use diagnosis and a comparison group. And this was also when excluding the persons who have substance use diagnosis of their own. That is, all the figures I've presented were the group without substance use diagnosis of their own. So we see a lower educational level and large differences in student status at early age, 20 to 24. The SUD siblings are less likely to be married, but yet more likely to be divorced or separated. We see that nearly 2/3 lived within an hour's driving distance from the patient. Fewer were fully employed, and there were more use of benefits in this group. And we found more sickness absence among those who were working. We also observed a higher use of health services and higher hospital admission rates. And for more specific conditions, we observed higher musculoskeletal consultations, but lower physiotherapy use. And this suggests perhaps underutilization of health services, which is also indicated in the fact that they do have more sickness absence, they do have more disability pension, yet they don't seem to use health services substantially more than others. So this is, we find this data very interesting. We think it's really exciting to work with this, but of course there are many challenges with registry data, and we do not get all substance use challenges or diagnoses here, only those who are registered. There are likely a lot of people who have problems that are never captured in the health systems. But we do believe the Norwegian data is quite good in comparison to many other types of data. It's difficult to interpret the health utilization data because we don't know if it's about the health itself or if it's about how people use the health services. And we do not know anything about the experienced family relations. Like, we don't know the amount of contact, we don't know who has a role as a caretaker and things like that, which is, of course, easier to explore in qualitative and perhaps service as well. So there are these are just like the main challenges with the study as we see it, but of course there are other challenges as well. And so this was what we have. There are some references here. So thank you.
Thank you so much for that. That was such an interesting and eye-opening presentation. So thank you both. That was really interesting. Now we will open the floor for any questions, comments, and discussions.
And is it written, or can I get it on the screen, or is it a verb?
I don't believe there are any questions in the chat, not that I can see. But if anyone wants to come, I know I see Jim's hands up, so if you want to come off of mute there.
Okay, can I ask my question now? Yeah. Good, thank you. Thank you very much for that. I mean, it's intriguing, and gosh, what good records you've got in Norway. I'm sure I don't know what our equivalent records are like, but I don't suppose they're a patch on the ones you've been able to use there. So well done for getting all that information. And there is so little on siblings, so it's really valuable to have more information about siblings. One of the things I couldn't help wondering about all the way through, it did look as if the siblings of those with substance problems were having difficulty. They were having children earlier. They were less often going into further education. They looked as if they'd got more health problems of their own, and so on. And the variable that was missing to me was something about socioeconomic status or area deprivation, because it did seem to me those differences could be accounted for if the two groups, the siblings and the comparison group, if they came from more deprived areas of the country, or if their families had been of lower socioeconomic status to start with. You'd expect those differences. And I appreciate it'd be very difficult to control that out, because of course if there were differences, some of those differences might well be related to the fact that the patients had the substance problems in the first place. So very, very difficult to deal with that. But I couldn't help feeling that was, that was lurking there as a possible explanation. I wondered if you got any comment on that.
Yeah, thank you very much for that question. It was an expected question. Well, there are different things to say about that. Like, first, we also find that it's tempting to control for socioeconomic status. But here we wanted to present the socioeconomic differences between these groups, because we thought that, okay, this group has its characteristics and their needs are related to these characteristics, regardless of why, regardless of what it's. Yeah, perhaps they come from families that are originally have lower socioeconomic status. Perhaps they are from deprived areas, but this doesn't matter if we want to map this for policymakers and advocacy organizations to see what these challenges are. So they are like, regardless of why they have these challenges, these are the challenges we observe. But then, of course, we are tempted to control for this and that. And we do have a parallel project where we try to identify causal effects. But that's like a completely different project where we try to use variables, sort of like instruments and things like that, because it's so difficult to control for background. But we do have analysis controlling for the family background. And these, I have this as a note here, so I have to see here. Sorry that it's not relevant on your slide, because this is only in my notes here. So when we control for parental educational level and income, when the parent was 30 years old. So this is likely before any manifestation of substance use in the child. We had a subsample with this kind of data, and we see that the group differences between the SUD sibling excluded group, like our main group, and a comparison were typically reduced. Of course, like if you look at socioeconomic status while controlling for socioeconomic status, you get a reduced effect. But we see that, okay, when we control for the parent situation, the differences we observe are typically reduced by 30 to 40%. So when we estimate at the same socioeconomic background, we found these attenuations. The exception was mental health outcomes, where the estimated differences declined by less than 20%. So we completely agree it's really relevant and it's kind of accounts for and explains, but we don't know if that is the purpose. But if we want to explain or account for this, these additional analysis highlights that not only the current low socioeconomic status, but also the low socioeconomic status family background is important. But it also suggests that there are still substantial health and work-related challenges beyond those encountered by other individuals from low socioeconomic status families. So did this answer the question?
Yes, thank you very much. I mean, you're terribly thorough. I mean, I'm not surprised to see you've actually done the work that I was thinking needed to be done, and which was possibly missing. It wasn't missing at all. You've done it. So, and I agree. It's so complicated. You know, very, very complicated to separate something which can't fully be separated. So yeah, thank you very much for the answer.
And it's so tempting to think like, okay, we have to explain, but do we always have to explain? Like, can't we just see, okay, what characterizes this group?
Yes, I very much take that point. Yeah, thank you.
Thank you.
And Richard's hand is up.
Well, firstly, thank you very much indeed. Some extremely interesting research and extremely interesting results. And let me also deal with something you raised right at the very beginning, which is, although we are taking a recording of this and we have your PowerPoint presentation, we will not put them on the website, which we normally would do within a week. We won't do that until you tell us that your paper has been accepted for publication. Okay, so you don't have to worry about that at all. I have actually quite a lot of questions, and I'm not going to ask them all now because I want other people to get in as well. But I'm very interested in the registration data, and of course this is something that I've been familiar with for a very long time. That in Scandinavia, you not only have a lot of registration data, but you have access, and you can get access to this registration data and cross-reference it in the way that you've done. And I suppose my first question is, could you just say a little bit about how you do that? How does that work in terms of confidentiality? I could imagine suggesting that in the UK, and obviously lots of people have suggested it in the UK, but it's extraordinarily difficult to get even within, for example, a single hospital group, to be able to actually cross-reference data from one set of patients with another set of patients. So how do you solve that in Norway? Because I know that confidentiality issues obviously must be extremely important in Norway as well. So how do you get permission to do registration work?
Yeah, so I'm not an expert on that, but first we have to get an approval from the regional ethical medical committee, something like that, and then each of the registries have to approve for the linkage. And there's always a battle going on for some years until you have the data. And then you negotiate like, okay, but you cannot get these type of diagnosis if you have these. And then some things are left out. And of course, when we sit and analyze, we think, oh, we should have had those diagnoses. We don't. And this is that these personal identification numbers are pseudonymized in different steps. So like we got data from someone who has another pseudonymized data. So like for us, it's quite far from the personal data. Yet there is so much data. So if we like really if we really wanted to, I guess it could be possible to identify individuals here, but we work in the health, like the National Institute of Public Health, and we have a signed declaration for not. So it's like the same with medical professionals. Okay, your general practitioner knows a lot about you, but he cannot tell it to anyone. Still, these analyses are done within a strict environment, which is not directly accessed. This environment can be accessed online, but it doesn't have other links to the internet. So it's very strict. Still, it's a lot of data, and some people would find it challenging to allow for such linkage. And I'm not. There are probably countries that this would be even stricter, but it is a battle to get this data. And
well, congratulations for fighting those battles, because
luckily we didn't have to, because we could just work with the data that another group had fought for many years, and then this became part of that project. So we were lucky.
Indeed. I'm just going to ask one other, and then I'll let other people get in. But well, actually, I'm not going to cheat. I'm going to ask two. Firstly, you define siblings via the mother, and I wondered why you didn't also define siblings via the father, because obviously you're potentially reducing your pool of siblings absolutely massively, and also you don't know how many of your control group people had fathers who had alcohol or other substance problems. So by ignoring fathers, isn't that causing a bit of a problem?
Yeah, I understand your question, but first, we do not select on the parents' substance use diagnosis. It's on the siblings, so that also goes for the mothers as well. But it's not. We have checked this, and well, the main reason is that these are persons. These are adult persons with a registered mother, and this group is typically well, it's in 2018, so those who were adults then grew up in a time where if there was a divorce, they would typically live with their mother. If there wasn't a divorce, we would anyway link them through the mother. If you understand me. So yeah. We checked how common it was to live with the father after a divorce, and it was extremely rare. Not extremely, but it was quite rare at that time of this data. Perhaps it's different today, but these were from 20 and more in 2018, and you typically live with your mother if there was a divorce. So it's not a huge problem. I don't remember how many thousand we missed, but it's not a huge problem in this data.
So the chances of a person in the control group being a sibling because they shared the same father, but not the same mother, you're saying would be very low.
Yeah.
Okay. I'll think about that, but I take your word.
I don't have the figures here, but it was we managed to convince ourselves that was the correct way.
Okay.
And also, it was important for us to be a bit strict because we didn't want siblings who were quite distal to their patient sibling included. It was more important to get the closer one, and that's why we chose the mother, because that is typically a more close bond.
Mm-hmm. Okay, one more, and then I'll stop. Which is this doesn't totally relate to your analysis, but I think it's important and interesting, and it's probably an analysis you've already done. But have you looked at how many of these sibling pairs had a parent with an alcohol or other substance problem? Have you looked at the intergenerationality of it?
Well, we do have similar analysis of parents, and we had a number of how many parents were also siblings, but not how many of the... No? Yeah, but not the other way around. So I'm not sure, but I think the important for this paper was not to account for things. It was to describe. So it wouldn't matter for us if their parents had a substance use problems or not. In research we will do, it's more important to account for these kind of things, because then we actually like to explain things. In this paper, we only want to describe and observe and see what the challenges and needs are of this group.
No, I understand that. It is in some ways tangential to this paper, but I am interested, as you have this data, to know how many of the people that you identified with substance problems were themselves children of people with substance problems, and how many of these siblings, therefore, who didn't have substance problems were also the children of people with substance problems. So I think that's a very, very interesting question. But I'll pass over to other people and come back later if there aren't any other questions.
Yeah, I agree that it would be an interesting additional number. There are very many numbers in the figures in this, but it's an additional piece of information that would be interesting. So thank you.
Any other questions? Feel free to write in the chat as well, if not. I have one question. It's maybe more curiosity. I was wondering if you've ever come across any other like similar registry studies that have been done with like other family members, so like a mother or a father.
Well, we have that study.
You do have.
We made two papers, and I think the parent study is out now, actually. So, in drug and alcohol dependence. So it came like some days ago.
Wow.
So you can see like similar variables, similar analysis for parents. Otherwise, there are quite few registry-based studies. There are some using pharmacology data, but it's more specific. We haven't seen any broad overviews. And also, it's like for researchers, it's quite difficult to do this kind of descriptive work. We always want some control and for some more specific topic. It's quite difficult to publish as well, because it's so broad, but still we believe it's valuable.
And yeah, Jim you have your hand up. Oh, and I think you're on mute, sorry.
You're quite right, I was. Yeah.
There we go.
Okay, sorry about that. Yes, I mean, if no one else wants to ask a specific question right just at the moment, I suppose taking your point about this is a descriptive study really, and therefore it's aimed at maybe identifying a group of people that policy ought to have something to say about. They ought to be included in policy considerations. It's a public health question. So it's not just a question to you, I don't think. It's a question to anybody else who's got any thoughts about it. So what is the next step for getting siblings recognized as important people in the substance abuse and families policy debate? And also related to that, I suppose, is the question of do we think that siblings are a particularly stigmatized group? Because stigma associated with being a family member of someone with a substance problem is something that's increasingly getting recognized now. I've certainly picked it up from things I've read. I spoke about it at the last AFINet conference, and it came up. I think it was a major theme in the AFINet conference in Quebec in May. So very, very general question, not just to you, but to anybody really. What do we do with the descriptive data now? And related to that question of stigma, do we think siblings are as stigmatized as parents, partners, others, maybe?
Yeah, I can. In our case, I think it's good that we collaborate with an organization who has this on their agenda, because our role as scientists is supposed to be objective, and we cannot say anything like about real implications of this. But I think our results are really needed by these organizations, and they will probably do their best with these figures, and they've waited for these figures. And yeah, so I think it's up to others to work with this. When it comes to stigma, I haven't thought much about it, but in my view, I think the data is more valuable because if you take care of this group, it can have benefits beyond the group. So it would have like a double effect if we were able to help this group. So I think it's really important for policies to be aware of these results.
I don't know if anybody else has got any thoughts on.
Oh, I see another hand up
Yeah.
there.
And this is one of our co-authors. So I think that's another.
Yeah, I just wanted to add that we work at the Norwegian Institute of Public Health, and I'm in the leader group in our division, and I try to argue that we should not only have a focus on the health of those having bad eating habits, or who smokes or who drink alcohol. We should also think about those harmed by this by others. Yeah, so I think it should be a big public health issue, because it as you see, I mean, there are quite big substantial differences, and I think it's it's a topic that needs more attention also in research, I think. So, but I think if we make more emphasis on it, then maybe also the politicians can see it better. That so I think it's our responsibility to point this out to the politicians.
I agree. Thank you.
Yeah.
I believe we have time for a couple more questions, if there's any more.
Torleif and Solveig, I just wonder if should we send a link to the parent article? Maybe they are interested.
Yeah.
Yes, please.
Yeah, please.
Yeah.
If you can put it on chat, that would be brilliant.
Mhm.
Yeah. Should I do it, or do you
Yes,
do it?
I don't have access to the chat here. So if
Okay.
you can do it, it will be good.
Yeah.
You can do it.
Okay.
Yeah.
Yeah. Okay, I will try to find it.
Thank you for doing that.
If the session ends before you have a chance to do that, then can you just email it to Jacqueline or myself,
Yeah.
and we'll circulate it.
Yeah, we can do that.
Definitely.
Thank you.
Richard, I don't know if you wanted to ask your remaining question.
No, I think we'll, a number of people have left already, so I think it's probably a good time for us to draw to a halt.
Yeah, awesome. Well, thank you so much, Torleif and Solveig, for sharing your research. It was so interesting and so fascinating, and I'm excited to read the other paper as well. And thank you to everyone else for joining us and for asking those questions and contributing to the discussion.
Thank
Have
you
a
very much for
lovely,
having us.
lovely rest of your Tuesday.
Can I just advertise our next webinar, which is in 2 months' time, on Tuesday, the 25th of November, where we have colleagues from Australia, Kathy Tulloch from the School of Health and Medical and Applied Sciences at Seacoast University, is going to be talking about understanding gamba-related harm to affected others, insights from Australian research. So I hope people will be able to make that as well.
Awesome. Thank you.
Okay.
Thank you very much. We really appreciate being here.
Thank you very much for such a lovely presentation. Thank you. Bye-bye.
Yeah, thank you.
Mm.
Bye, everyone.
Thank you.
Bye.
Thank you.
Bye.
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 Bye.